evening, everyone, and welcome to today's webcast, B-Joint Smart Part 1. My name is Corinne Pettit, and I'll be your moderator for tonight's presentation. Before we get started, I'd like to go over a few tips so that you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You've joined the presentation listening using your computer's speaker system by default. This means if you can hear music through your computer, you should be able to hear the presentation. If you'd prefer to join over the telephone, just select Use Telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenters by typing into the questions pane of the control panel. You may send in your questions at any time during the presentation, and we will collect these and address as many as possible at the end. So before I introduce today's speakers, I'd like to take a moment to tell those of you who may be new to the Foundation about who we are, our mission, and what we do. In 2014, the National Psoriasis Foundation developed a new strategic plan which drives everything we do as an organization. To achieve our mission, the following goals were identified. Number one, accelerate discovery to cure psoriatic disease by increasing funding to the NIH to more than $18 million, increase the number of scientists studying psoriatic disease, creating a community of people who participate in psoriasis and psoriatic arthritis research, and invest in NPF funding for research. Number two is to improve health outcomes. We do this by increasing the number of people receiving appropriate treatment to 77% of those diagnosed with moderate to severe psoriasis and 62% of people with psoriatic arthritis. Another goal is to reduce from 50 to 30% the number of people who report psoriasis and psoriatic arthritis as a problem in their everyday life, and publish progress reports in key areas of psoriatic disease care and related health diseases. And finally, number three is to achieve our goals to help reach our mission, whether it's being involved with an event or becoming a volunteer. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis to help manage your disease and to find others who understand what it means to live with psoriatic disease. So one of the ways we accelerate discovery is through the NPF Corona National Psoriasis Patient Registry. Launched in 2015, it's the largest independent observational registry of psoriasis patients in the United States. The registry collects and studies patient health information, allowing researchers to compare the safety and effectiveness of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. There are currently more than 2,450 patients enrolled at more than 115 sites across the country. To be eligible to become enrolled in the registry, you must first meet the following criteria. You must be diagnosed with psoriasis. You must have started on or switched to an eligible systemic psoriasis treatment within the last year, and eligible medications are FDA-approved biologic treatments. Your dermatologist must be enrolled as an NPF Corona National Psoriasis Patient Registry site. If you're not sure if they are, ask, and if not, encourage them to join. If you're interested, talk to your dermatologist about whether you're enrolled as a site with the NPF Corona National Psoriasis Patient Registry and determine whether you meet the eligibility requirements. Then you will work with your provider to complete Corona psoriasis questionnaires during your routine visits. The questionnaires only take about 10 to 15 minutes to complete, and that's it. So we continue to improve health outcomes through our Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. Whether you've been newly diagnosed or have lived with your condition for years, the Patient Navigation Center can answer your questions about psoriatic disease. Our team of patient navigators can help you find specialists, learn about new treatments, and connect you to others in the community who are living with psoriatic disease. We'll work with you one-on-one to make sure you're receiving the best care, treatment, and support needed to manage your disease. We would not be able to move our mission forward and achieve our goals that we just outlined without the generous donations we receive. Please consider giving today. Just think, your gift could help us discover the next breakthrough treatment for psoriatic disease. I would now like to take a moment to introduce you to our B-Joint Smart program. The National Psoriasis Foundation identified a need for people with psoriatic arthritis to be aware that preventative measures can be taken to limit joint destruction and the possibility of being disabled. Research has shown early diagnosis and ongoing treatment can reduce the risk of permanent damage to joints. NPF, in collaboration with Amgen, originally developed this B-Joint Smart program to provide educational opportunities that empower those who have psoriatic arthritis to learn more about their disease and treatment options to help preserve joint health and limit damage associated with progression of the disease. We also offer resources that provide support and encouragement when faced with a diagnosis of psoriatic arthritis. There are resources that can help encourage those who live with psoriatic arthritis to live a healthy life while managing pain and swelling and stiffness of joints. Those goals continue today as part of the Foundation's Psoriatic Arthritis Project. So let's talk about what you can expect to learn today. You will hear an overview of how and why psoriatic arthritis develops, the effect of skin inflammation on joints, the range of symptoms and pain associated with this disease, and the value of early intervention versus delay of treatment. You'll also find out about successful strategies ranging from lifestyle changes to non-medical and pharmacological treatment options for pain management and to limit progression of joint damage. Finally, you'll learn about more preventative care that can help ensure you are able to do the activities you love and to live a life less impacted by painful, stiff, and swollen joints. On behalf of the National Psoriasis Foundation, I'd like to recognize our sponsors, presenting sponsor Novartis, and our national sponsors Celgene, AbbVie, Lilly, and Mallinckrodt for their efforts as part of this collaboration to provide an opportunity to learn more about psoriatic arthritis. Without their support, this educational program would not be possible. Now I'd like to introduce tonight's first speaker, Dr. Ronald Presec. Dr. Prussick is the medical director of the Washington Dermatology Center, a comprehensive facility specializing in the treatment of the diseases of the skin, hair, and nails in Rockville and Frederick, Maryland. Dr. Prussick is also an assistant clinical professor of dermatology at George Washington University School of Medicine, where he inspires, mentors, and teaches dermatology residents. He has received extensive training in the specialization of laser treatments and treatment for psoriasis. Dr. Presec has helped develop new FDA-approved therapy options. He has consistently been voted one of America's top physicians by the Consumer Research Council. He's also a member of the Foundation's medical board. We are honored to have Dr. Presec join us to help provide a greater relationship between psoriasis and psoriatic arthritis. Welcome, Dr. Presec.
Well, thank you very much for that really great intro, and welcome everyone to this webinar. I'm going to try to give you some really helpful tips on how to manage your skin, and Dr. Siegel will then give you some management tips on your joints for your arthritis. Okay, so let's just start with talking about psoriatic disease. So we now really think of psoriatic disease as a systemic inflammatory disease, as opposed to just a disease of the skin or the joints. And we know that there's a genetic predisposition to it, and we know that it is triggered by many different things that we'll talk about. It can appear at a young age, or often teenagers can get it, or young adults, and it can get worse at times and better at times, and 1 in 3 people can develop psoriatic arthritis. One of our goals really now in our teaching with the National Psoriasis Foundation is just to get dermatologists to ask about patients' joints, not just specifically about joint pain, but other things as well, because we want to try to diagnose psoriatic arthritis sooner. The problem with psoriatic arthritis is there isn't a simple blood test that we can do to confirm it. So it has to be made by a clinical diagnosis. And this is a complicated slide because it shows how many different proteins and immune cells and cytokines are involved in developing psoriasis and psoriatic arthritis. So just to give you an idea, cytokines are proteins that are produced by cells that actually bind to receptors and then have it a function in your body on the different cells. And if you have too many cytokines in one area, that could promote psoriasis and psoriatic arthritis. So what you can see here on this slide, when you look just under where it says skin, there are different pathways that researchers have found that actually cause the skin problems. So for example, tumor necrosis factor alpha, which is an important protein interleukin 12, interleukin 23, interferon, and then interleukin 17 are also very important proteins. And now many of the new biologics that we have actually bind these cytokines and bring them down to normal levels to try to help clear the skin and help the joints. So that's basically what we're focusing on in our research studies and in the treatments that we currently have. There are many different triggers for psoriasis. Most patients with psoriasis will tell us that stress is a very important trigger for people. And stress can come in different ways. Sometimes just lack of sleep or not sleeping enough can cause stress to the body, even if you don't personally feel stress. So getting a good 7 to 8 hours a night sleep is very important. Certain medications can trigger it too. Commonly, when people take prednisone and the prednisone is stopped, then the psoriasis can flare up. Other medications like beta blockers or lithium are known to trigger psoriasis. Infections as well, and it doesn't just have to be skin infections. It could be an infection in your tooth or having a bowel infection. Anything like that can trigger the immune system to become overactivated if you have a genetic predisposition to developing psoriasis and psoriatic arthritis. Even an injury to the skin, so it's very important not to scratch your skin and not to rub it too hard to remove the scales, because that is causing injury to the skin, which could make your psoriasis worse. We know that too much alcohol and tobacco use can trigger psoriasis. Weather changes, specifically for the skin, dry weather, because when people get dry skin, their skin gets tiny little cracks and wounds in it, and that can promote immune cells to come from the blood into the skin to trigger psoriasis. So when the weather changes and winter comes, it's important to cut your shower time down, use mild soaps, and moisturize your skin. We're going to talk a little bit about food choices and diet as well too in the upcoming slides. The types of psoriasis, just to review, commonly we see plaque psoriasis, which are very well demarcated red scaly plaques that come in very specific areas, and that's how we differentiate it from eczema. Because if you look at a red scaly spot, a lot of people think it may be eczema, but that's why a dermatologist needs to confirm that you actually have psoriasis and not eczema, which can sometimes fool people. The guttate type of psoriasis is teardrop-looking spots that appear often on the trunk and extremities after strep throats. And there's a slight genetic difference between the guttate and the plaque psoriasis. But some people with guttate psoriasis may develop plaque psoriasis over time. Usually the guttate patients are young children or teenagers that develop strep throats. Erythrodermic psoriasis just means that the skin's all red, and a lot of people have plaque psoriasis, but if they get an infection or stress, or if they take prednisone and it's stopped too quickly, they may develop erythrodermic psoriasis. Pustular psoriasis just refers to the fact that you see small little whiteheads that look like pustules on the skin. Some people have plaque psoriasis, and then with a trigger, it may turn into pustular psoriasis, such as with prednisone use, or an infection, or some people just have a completely different genetic condition where they only get pustular psoriasis and never plaque psoriasis. Inverse psoriasis refers to psoriasis that comes in the folds, so in the armpits, the groin. They're very difficult to treat in those areas because many of the topical treatments we have are quite dangerous to use for a long period of time in those areas. And then palmoplantar psoriasis just refers to psoriasis on the hands and feet. Some of those people can have plaque psoriasis elsewhere, but that's a special condition because it's just so hard to get that condition under control when it's on the hands and feet, often because of kebnerization, where people have to use their hands, so they're washing them a lot of soap and water, and walking causes trauma on the skin, and it makes it very difficult for us to treat the psoriasis. So that's a little review of the types of psoriasis. Now, we came up with criteria on how to define psoriasis as mild, moderate, and severe, so patients and dermatologists could know really what type of treatment we should expect to use for patients. So the easiest way to do it is to think about body surface areas. So 1 palm worth on your hand, including the thumb, is considered 1% BSA, body surface area. So if you have three palms worth or less of psoriasis on your body, your condition is considered mild. If you have 3 to 10 palms worth, it's considered moderate. And if you have more than 10 palms worth, it's considered severe. But there's a lot of exceptions to that because we ask about quality of life. How does it affect you? So if you just have this on your hands and feet, you may have less than 3% body surface area, but for you, your condition is severe, and then we have to consider using the medicines we have for moderate to severe psoriasis because it is severe for you. So hard to treat areas like the scalp, the palms, the soles, the folds, the face, those are all considered severe, including nail psoriasis as well, which is very difficult to treat. In the nail psoriasis, what we're looking for, and often rheumatologists will look for nail pittings because that's an important criteria to diagnose psoriatic arthritis. And it's very difficult to treat nail psoriasis with topicals as well. So we have a lot of studies with our new systemic and biologic treatments to look at nail psoriasis. But it's a big clue to us for the development of psoriatic arthritis. Now, not everyone with nail psoriasis will get psoriatic arthritis. It's just a clue and a risk factor, but it's not a guarantee that people can get psoriatic arthritis if they have nail psoriasis. There's many different things we look for. We look for pits, we look for lifting of the nail off the nail bed, that's called onycholysis, or thickening or crumbling or hyperkeratosis. What's important for you to know if you have nail psoriasis, keep the nails short, because if they're too long, when you go to reach for something, you can bang your nail against the table and lift it up even more. So keep it short, and also make sure you don't get water under the nail. So keep it dry, using a blow dryer after you wash your hands for a few seconds to dry the water that goes under the nail is helpful, because if too much water accumulates under the nail, you can get a fungal infection, and your dermatologist will have to take a little culture of your nail to see if a fungus is growing. Dr. Siegel will go into greater details on the symptoms of psoriatic arthritis. I'll just say that it's more than just joint pain. It can just affect you in many other ways, such as stiffness in the morning, or fatigue, or tendon pain in your heels or your elbows, or lower back issues. So Dr. Siegel will describe that in more details and go through all the symptoms of psoriatic arthritis. So what are the other factors associated with inflammation? As I said, that patients with psoriasis and psoriatic arthritis, we think have a systemic inflammatory disease. So the immune cells are not just in the skin and joints, but they can go in other areas. And we've had recent studies that show that people with severe psoriasis can have more heart attacks and strokes because inflammation can appear in their blood vessels. Or we can see patients with fatty liver disease, because fatty liver disease can be caused from systemic inflammation, which can cause not only fatty liver disease, but for the fatty liver disease to develop into a more severe form called NASH, non-alcoholic steatohepatitis, which can be quite dangerous for your liver. So those are all things that can happen when people have systemic inflammation. There's also some data that shows that depression can be caused from elevated cytokines from inflammation as well. So what are the things you can do? Well, we talked about the trigger factors. I think it's important to make sure that you avoid drinking a lot of alcohol, avoid smoking, keep your weight down. We know that patients, when they gain weight over time, that causes more systemic inflammation. Their psoriasis can get worse or more difficult to treat. So if you have a problem with your weight, you need to get help on how to reduce your weight. Try to exercise at least 30 minutes a day, and try to eat a healthy diet that includes omega-3 foods like oily fish and chia seeds. A Mediterranean diet has been shown to be very helpful, using olive oil and fruits and vegetables, and stay away from omega-6 foods like red corn and soy, and avoid packaged goods as well. So those are all little things that you can do to take control of your disease. Another thing that's helpful is to get your vitamin D levels checked when you go see your doctor, and to correct those. Another thing is to avoid high fructose corn syrup, because that could make fatty liver disease worse. So in terms of treatment options, we'll go through them and just give you a little review of some of the things that we're doing. One of the papers we wrote in the medical board in this last year was a target response. We felt that too many patients in this country and other countries with psoriasis were not getting proper treatment. So a lot of people who had severe psoriasis were getting a small tube of cortisone cream and being sent home and not really getting the treatment that they need. And so we wrote this article that our target goal would be to get patient psoriasis down to 1% or less, ideally. So this just shows that when we start treatment, after 3 months, we recommended that dermatologists see their patients again, and hopefully their skin should be in a 3% body surface area or less. And then 6 months later, we would see them again, and hopefully they're closer to the 1% range, and we would follow them every 6 months. And we put in the article that if patients are happy with their current treatment and they're doing well, even if they're not at 3% or less, it's okay. It doesn't have to be 1% to get the results that patients are looking for. So it's up to the doctor and the patient to make the decision, the final decision on what they're happy with, but that's our ideal goals. So the treat to target goals were really, like I said, to just give people an idea of what we should be expecting and how often patients should be seeing their dermatologist. In terms of the topicals, what's important to know is that topicals are really for patients with mild psoriasis, 3% body surface area or less, or if they have severe psoriasis and they're getting treated, if there's still some residual psoriasis, they can use topicals. So there's many over-the-counter products that are available. My favorite is Aloe Vera, because Aloe Vera has an anti-inflammatory property, and it also helps a lot with pigmentation problems. So a lot of people, after the psoriasis goes away, that leaves a residual pigment discoloration on their skin, and Aloe Vera is very good for that. I also like to use tea tree oil, especially on the scalp, and I like to use a product called Indigo Naturalis, which is available, and that's a good moisturizer for the skin and also for the scalp. The prescription topicals considered widely available use are the corticosteroids. The problem with the corticosteroids is there's many different strengths, and you have to be careful when you use the strong ones not to use them for too long on your skin, because they could thin the skin out, especially in thin-skinned areas like the folds or the face. So you have to be very careful with using those, and you have to taper them slowly rather than stop them quickly to prevent a flare of your skin in some people. We also use vitamin D creams and ointments, and vitamin A creams as well are good for thick skin areas like the palms or the scalp. We also off-label use eczema creams that don't have steroids for face and folds, where we can't really use topical steroid creams because of their skin thinning effects. There's some new products that we'll just review quickly. There's one called Enstolar Foam made by Leo Pharmacy. It's a once-a-day application, and it's a mix of the vitamin D and the steroid together, similar to what what Taclonex was, except it just comes in a foam area. So a lot of people find that convenient to use. Because of the steroid in it, you can't use it for a long period of time though, but it is quite effective. There's another steroid spray that you can use that's kind of similar to clobetasol spray, but it's called Cernivo, which contains betamethasone spray, which also can be used for 2 to 4 weeks at a time. And a lot of patients like to use a spray because it's a little bit easier to use and a little less sticky than an ointment. In terms of light therapy options, we used to use broadband UVB, which means that it's the whole range of wavelengths across the whole UVB spectrum. But now we use narrowband UVB, which is 310 nanometers, and that is the most effective wavelength. And the reason why we use the narrowband is because we can treat the skin with much higher energy levels and get a much better effect, because broadband at those high energy levels would just burn the skin. So we couldn't really use high energy levels. So now most dermatology practices use narrowband. So we use it in the booths when you have severe psoriasis all over, or we use it as a laser if you just have focused areas that we need to treat. So if it's just on the scalp or the hands and feet, or if you have a few residual areas after being treated with a biologic or the light box, the big light box, we can switch to the Eczema Laser, where you'd have to come to the office 2 or 3 times a week. But it works quite well, and once it's clear, we can often get people in a remission for at least 6 months with phototherapy. There's a new home light treatments. Now, we traditionally used light treatments from different companies like Davlin or National Biologic. There's a new one out called Clarify, which is a home light therapy system that you can buy. You need a prescription from your dermatologist, and it's a little bit more high-tech in that it connects to an app on your smartphone, and that data can be sent to your dermatologist so they know how many treatments you're doing and at what dosages. The traditional treatments that we used for psoriasis before the biologics came out are called systemic treatments because they're pills. They're cyclosporin and methotrexate and soriatane, and sulfasalazine we used very infrequently. And we don't use them as much anymore because they don't quite work as well as the new treatments that we have. And they have cumulative toxicity, which means that the more you use it, the more the toxicity occurs over time. So for example, with methotrexate, the more you use it, the more it can damage the liver over time. Or with cyclosporin, the more you use it, the more it can damage the kidneys over time. So we tend to, in dermatology anyways, use them for a shorter period of times than we used to, and now switch to the newer medicines. There's a new systemic treatment that has been available in the last few years called Otezla, or apremilast, and it's a pill that you take twice a day. In the first week you take a lower dose because a lot of people can get some stomach upset, like diarrhea or nausea or headache, and that usually goes away in the first 2 weeks. And the nice thing about apremilast is we don't have to do blood work monitoring, and it doesn't have the cumulative toxicity to the liver that you would have with some of the older medicines, and that's why many dermatologists choose to use Otezla. We have many biologics, and they're not so new anymore. Enbrel and Humira have been tested for over 20 years now, and we have a lot of long-term safety data on them, and they're quite commonly used in dermatology practices. We also have Stelara, which blocks interleukin 12 and 23, which has been around for 10 years. Then we have some newer ones that we'll talk about. One of the nice things that we have available now is we can treat children between the ages of 4 and 17 with Enbrel, and that's been recently FDA approved for psoriasis. It also works for psoriatic arthritis, and Enbrel and Humira have been used for more than 10 years in the treatment of juvenile idiopathic arthritis. So now we're very happy that we can treat our children on label with Enbrel. We also have some new FDA approval this year with Stelara for adolescents of the ages of 12 to 17. and this is an injection that often we give in the office. We give that initially, and then a month later, and then every 3 months the patients come into the office, and we get very pleasing results for our patients with Stelara as well. There are some other new medicines that have been out. As I showed you at the beginning of the presentation, in terms of the cytokines that are elevated in psoriasis, one of them is called interleukin-17, and that's a very important pathway in triggering the psoriasis inflammation. So these antibodies actually bind the interleukin-17, and they bring the levels down to a normal range, and they help the psoriasis get better. So one is called Cocentix, that was developed by Novartis, which is given as a weekly injection for the first 5 weeks, and then it's a monthly injection. And it's also used for psoriatic arthritis. Another interleukin-17 that's now available from Eli Lilly is called Taltz, and that one, the injection is given at week 0 and then every 2 weeks for the first 3 months, and then a monthly injection. There are studies ongoing about use for psoriatic arthritis. There's another interleukin inhibitor. This one is called Siliq, and it's from Orthodermatologics, and it works differently from the other two in that the antibody doesn't bind the interleukin-17 itself. It actually binds the receptor. So the interleukin-17, when it's trying to bind to the receptor, it can't do it because this inhibits that receptor. And therefore, the interleukin-17 can't have the effect on the immune system to cause the psoriasis. So that's the newer one that came out. There is a black box warning with this one about the risk of suicidal thoughts or behavior. So your dermatologist will have to ask you about that before they give you this medicine. Another new one that's recently out this year is called Tremfia. It's made by Janssen, who makes Stelara, and it's similar to Stelara, and Stelara binds interleukin 12 and 23 through an antibody, and this is an antibody that just binds interleukin 23. And what's different about it from Stelara is that it's just the same dose for everyone. It doesn't matter what your weight is, and it's given every 8 weeks instead of every 12 weeks. And dermatologists are seeing very nice results with this one as well. There are some interleukin-23 inhibitors that are under study now for phase 3 clinical trials, one by Sun Pharma and the other one by AbbVie. And hopefully those drugs will be available to you soon too. So this is my last slide, and it's just giving you a basic review of what we talked about, in that I think that our goal is trying to treat your skin as aggressively as possible and bringing down the inflammation in your skin, because we believe, and we're studying this right now, that if we can treat your skin disease, it might prevent or reduce some of the comorbidities that are that we see in patients with psoriasis, such as fatty liver disease and the heart and stroke problems. And that's what we're trying to understand, is if we can improve your skin, can we improve those comorbidities? So what you can do is try to make sure you eat a healthy diet. Like I said, focus on omega-3 foods. Don't drink a lot of alcohol, don't smoke, keep your weight down, get your vitamin D levels checked, focus on eating a Mediterranean diet, and I think those are all things that will help you control your disease along with the medications that your dermatologist gives you. So now I'm going to pass this on to my good friend and wonderful rheumatologist, Dr. Siegel, who will teach you about psoriatic arthritis.
Great. Thank you so much, Dr. Presec. And so I would like to now introduce our next speaker, Dr. Evan Siegel. Dr. Siegel is a rheumatologist in private practice. There he is, with Arthritis and Rheumatism Associates in Rockville and Wheaton, Maryland. While he cares for all rheumatic diseases, Dr. Siegel has a special interest in psoriatic arthritis and other spondyloarthropathies such as ankylosing spondylitis. Dr. Siegel serves as the Medical Director of Arthritis and Rehabilitation Therapy Services, which is the physical therapy division of Arthritis and Rheumatism Associates. He is also an assistant clinical professor of medicine at Georgetown University School of Medicine. He is a member of GRAPPA, the International Group of Research and Assessment of Psoriasis and Psoriatic Arthritis, and is a contributing author to the group's treatment guidelines. Dr. Siegel has been chosen to sit on the committee to develop treatment guidelines for psoriatic arthritis for the American College of Rheumatology. He has consistently been voted as one of the best doctors in America as an outstanding specialist in rheumatology. Dr. Siegel is also a member of the Foundation's Medical Board. We're honored to have Dr. Siegel join us for today's presentation about the symptoms, classifications, and treatment options for psoriatic arthritis. Welcome, Dr. Presec, or Dr. Siegel.
Well, thank you so much, and thank you for that beautiful introduction. And I want to really thank the National Psoriasis Foundation for doing this program and beginning to really raise awareness of psoriatic arthritis. Really, there have been a big focus on psoriasis for many years. The movement to thinking about psoriatic arthritis as a systemic illness, as psoriatic disease, overall is fairly new. I've been treating this disease for over 28 years at this point, and you have to say that number one, the amazing more recent advance is the increase in awareness of psoriatic arthritis. And number two, as I told a 16-year-old patient that I diagnosed today with psoriatic arthritis, if there ever was a time to have psoriatic arthritis, now is the time. 30 years ago, 35 years ago, there really was very little to do for this disorder. But now we have so many wonderful interventions that can be used, as I will talk about, Dr. Prussick just outlined for you. Really, the whole field of psoriatic arthritis is a hotbed for research right now. So really very, very positive time to be treating this disorder. Hang on one second here. There we go. Have to just get these controls right. There we go. Okay, so what I'm going to try to address is psoriatic arthritis tonight and introduce you to the disease process and some of the things that we can do to treat this disorder and how we can differentiate it from some of the other types of arthritis that are out there that can be really quite confusing, both to patients and to medical professionals. So with psoriatic arthritis, there are a few key things that we think about. First of all, it is a form of arthritis, which means that there is going to be inflammation and swelling of the joints, but this particular type of arthritis can affect a few or many joints and also can affect the spine. So that's very different than some other types of arthritis like rheumatoid arthritis, which really only affects the joints. In addition, we also see inflammation of the entheses. The entheses are the areas where tendons attach to bone, tendons and ligaments attach to bone. That's areas like the outer aspect of the elbow, sometimes causing symptoms like tennis elbow, or where the Achilles tendon attaches to the bone. And often this is not recognized as a major form of psoriatic arthritis and can often be missed as an early symptom of this disorder. The symptoms that you may feel would be joint pain, of course, stiffness in the morning. We generally say at least 30 minutes to an hour of morning stiffness is of concern for inflammation. Everybody, when they get up first thing in the morning, or many people, will feel a little bit of stiffness, but if it's gone in a few minutes, probably not as worrisome as if it's hanging on for 30 to 60 minutes. We also look, as I'll outline for you shortly, for complete swelling of a finger or toe, what sometimes is called a sausage digit. And as Dr. Prussick touched on, we look for nail changes because that does seem to be highly correlated with psoriatic arthritis in people with psoriasis. So more than 80% of people with psoriatic arthritis will have nail changes, where probably only about 30 or 40% of patients with just psoriasis will have the types of nail changes that Dr. Prussick showed you earlier. So that's sometimes we look for those as potentially a predictor of who is going to develop psoriatic arthritis. So what about other types of arthritis? So somebody has psoriasis and all of a sudden they begin to develop joint pain. How do we know whether it's psoriatic arthritis or whether it is some other form of arthritis? Well, each type of arthritis has its own typical features, its own typical presentation. Osteoarthritis is a very common form of arthritis, generally develops as people get a little bit older. We think of it as a wear and tear type of arthritis because the cartilage that is sitting between the bones in the joints can break down over time. That causes joint space narrowing, that causes rubbing of one bone against another, and that causes pain. We think there is a little bit of inflammation associated with that, but not the kind of inflammation, the big puffy inflammation that we can see with psoriatic arthritis or with rheumatoid arthritis. Additionally, generally joints that are involved with osteoarthritis will develop bony changes and bone spurs, and that can happen at any of the joints. And that's why one of the things we often look for is sort of a bony, knobby appearance of the joints, particularly at the fingers, at the end joints of the fingers and the middle joints of the fingers. Those actually have specific names called Heberden's and Bouchard's nodes. And those are typical of osteoarthritis. If you think about your grandmother's hands, chances are there were some knobby changes that probably were osteoarthritis. And I would dare to suspect and predict that some of you out there listening right now, if you look down at your hands, would see some knobby changes. We also often have some grinding and movement of noises with movement of the joint at the knee in particular. We have a great name for that. It's called crepitus. Crepitus is a sense of grinding with movement of the joint and is often more consistent with osteoarthritis than other forms of inflammatory arthritis. What about rheumatoid arthritis? Sometimes difficult to differentiate from psoriatic arthritis. One of the key things with rheumatoid arthritis is that it inflames primarily the joints, the tissue within the joint called the synovium. It can go on to cause significant joint damage if untreated. One of the key features that really is fascinating about rheumatoid arthritis is that it tends to be symmetric. So if a wrist on one side of the body is affected, then a wrist on the other side of the body will also be affected. If one knee is inflamed, generally the other knee will be inflamed as well. That's very different than psoriatic arthritis, which tends to be asymmetric in presentation. Again, the symptoms are the classic symptoms of joint inflammation, joint pain, swelling, and that same morning stiffness that we were talking about earlier. And we can see significant flares intermittently associated with severe inflammation. But overall, the presentation, the symmetry, the type of inflammation that's present helps a rheumatologist to differentiate this disease process, rheumatoid arthritis, from psoriatic arthritis. What about gout? Benjamin Franklin's disease. We know exactly what causes gout, unlike many of the other types of arthritis that occur, and that is excessive uric acid in the bloodstream. So that can occur from either overproduction or under excretion. So the most common reason is because the kidneys stop getting rid of uric acid very efficiently. And over time, that causes uric acid to deposit along the joint space and joint surfaces, along the cartilage, and it can just sit there for a long time. It can also deposit into the skin, and those are called tophi, little nodules that can occur in the skin, often in areas of pressure or cool areas of the body. those deposited crystals under certain conditions can come off the joint surface, go into the joint fluid, and cause intense inflammation. The classic description of gout is that the pain is so severe that even a sheet touching the affected toe or the slamming of a door can cause excruciating pain. There are classic pictures of a devil putting a pitchfork into a joint to try to describe the pain associated with gout. The difference between gout, though, and some of the other types of arthritis we've been talking about is that it is generally self-limited. So people who have an acute gout attack are in intense pain for a period often of several days or a week, sometimes even two, but then the inflammation does go away on its own or with the help of some medications, and then the joint goes back to normal. Not so with psoriatic arthritis. However, any process that causes extensive cellular turnover can produce a lot of uric acid. So, for example, somebody who has leukemia and undergoes chemotherapy, or has a disorder of the red blood cells where many of them are overproduced, that excessive production of cells and then the breakdown of those cells causes eventually a production of uric acid through the breakdown of purines, which are part of normal cell metabolites. In psoriasis, where there is an overproduction of skin cells, we often can see an elevated uric acid, and sometimes gout can complicate psoriasis, and that is something, again, that a specialist can be helpful in differentiating. Let's focus in a little bit more on psoriatic arthritis. I mentioned to you that it can affect a few or many joints. So it's called oligoarticular when it's 4 or fewer joints, and polyarticular if it's 5 or more joints. This sometimes impacts the way we think about the severity of the disease, of course. And then there are several other areas that can be involved that I mentioned already, and we call these domains. So there are 5 different domains that we think about in the treatment of psoriatic arthritis. One, of course, is the skin. Another is the joints. And then another are the entheses that I mentioned to you earlier, the areas where tendon attaches to bone. Dactylitis, which is the sausage digit that I mentioned earlier, the complete swelling of an entire digit. That's generally a finger or toe, or spondylitis, which means inflammation of the spine. We'll touch on each of those. So enthesitis, again, that shows you how it's pronounced, and that is inflammation where tendon and ligament connect to bone. I mentioned that characteristic areas are the Achilles tendon, plantar fasciitis, where the plantar fascia that forms the bottom of your foot attaches to the heel. The elbows, particularly at the lateral or the outer or inner aspects, and that can be mistaken for tennis elbow or golfer's elbow. So it is not uncommon for me to see patients coming in who've been seen by their podiatrist. In fact, like this person whose picture I have up on the screen here, who presented with this significant swelling at the end of the Achilles tendon that just was not getting better. So it's not uncommon for me to see people who've been seen by podiatrists for months on end with Achilles tendonitis or plantar fasciitis that just won't get better. Why won't it get better? Because it isn't just routine Achilles tendonitis or plantar fasciitis, secondary to playing tennis or walking barefoot too long. This is actually an inflammatory process and needs to be treated in the same way that other forms of psoriatic arthritis are. What about dactylitis, the sausage digit that I told you about? So this is inflammation of an entire digit. It could be a finger or a toe. It could be one finger or one toe, or multiple fingers and multiple toes. We now know that from a number of MRI type studies of dactylitis, we know that multiple parts of the digit are inflamed. In general, all 3 joints of that digit are inflamed. So the knuckle right at the end of the palm, the knuckle in the middle of the finger and the knuckle at the end of the finger, called the MCP, PIP, and DIP joints. Generally, all three can be inflamed. The tendons and ligaments in the digit are often inflamed as well. And we even know that the bone underneath all of that is actually inflamed too, and in the worst cases can sometimes be mistaken for an infection. This does occur in a lot of patients with psoriatic arthritis, between 30 to 50%, and is really quite characteristic of psoriatic arthritis. We often say pathognomonic because there are very few other diseases that can present with dactylitis. Very rarely some of the other spondyloarthropathies like ankylosing spondylitis or reactive arthritis. But in general, when I see dactylitis, I think psoriatic arthritis. And then, as I mentioned, the spine can be involved as well, and that's called spondylitis. And again, very different than rheumatoid arthritis, which does not affect the spine. Very different than gout, which really does not affect the spine. This occurs in about 40% of people with psoriatic arthritis, but very rarely as the only manifestation. So probably only about 5% of people only have the spine involved. And the presentation is with inflammatory type back pain. Inflammatory back pain is different than mechanical back pain. So probably everybody out there has had mechanical back pain at some point, because 95% of the population will have mechanical back pain at some point in their life, and that is when you bend over to pick up a heavy suitcase or a trunk, and all of a sudden your back goes out. And classic situation then is that you want to rest that back. You want to go lie down, and you feel much better with lying down. And if you get up and try and move, it hurts like crazy. Inflammatory back pain is the opposite. It actually is worse with rest and better with exercise, so improves with exercise. People with psoriatic spondylitis or even ankylosing spondylitis, when they wake up in the morning, have terrible back stiffness that often will last for at least 30 minutes to an hour. It improves with exercise. It tends to come on with a gradual onset, unlike the acute mechanical back pain, which usually is quite sudden. And it often causes pain in the middle of the night. So people will often wake up with back pain in the middle of the night, have to get up, move around, because that movement actually causes improvement, and then go back to bed. So these are the characteristics of inflammatory back pain, and really need to be paid attention to in patients who present to their doctor with back pain, because it is the second most common reason for someone to go to the doctor, only surpassed by the common cold, back pain. So how do we make the diagnosis? How do we classify something as psoriatic arthritis? And this is a group of features that were put together by GRAPPA, the group that I belong to, the group for the assessment, a group for research and assessment, psoriasis and psoriatic arthritis, which is an international group made up of both rheumatologists and dermatologists. These criteria were come up with really to bring people into clinical trials so that everybody that came into a clinical trial looking at a new medication would actually have psoriatic arthritis. But we do think about them as a way to diagnose psoriatic arthritis as well, just not as well validated for that. So how do you make the diagnosis? Well, you start with the presence of inflammatory articular disease, what I just told you about. That could be the spondylitis, it could be arthritis, it could be enthesitis. And you need to have 2 or 3 of the following features. So either current psoriasis or a past history of psoriasis, or for the first time, you might, in criteria for this disease, you might just have a family history of psoriasis in a 1st or 2nd degree relative. Once again, that nail psoriasis shows up in how important it is, and here used for the classification of the disease itself. In general, the rheumatoid factor test that we use to screen for rheumatoid arthritis should be negative, although a very small percentage of patients with psoriatic arthritis will be positive for that. Current or a history of dactylitis, current dactylitis or a history of dactylitis, that's what we just talked about. Often these criteria have in parentheses as diagnosed by a rheumatologist, because it turns out that very few professionals other than a rheumatologist and a few special dermatologists know what dactylitis actually is. And then there are certain X-ray changes which help us to make the diagnosis. If you meet these criteria, if you have that inflammatory articular disease and you have 2 or 3 of these characteristics, then it is about 98% sure that you have psoriatic arthritis. That's how specific these criteria are. What else do we use to make the diagnosis of psoriatic arthritis? Well, as Dr. Prussick said, there is absolutely no blood test that can convincingly make the diagnosis of psoriatic arthritis. It is this combination of clinical features. But there are some blood tests that we do look at, and that's a sedimentation rate, which measures inflammation in the whole body. Same thing as that's measured by the C-reactive protein, CRP. Both of those are measures of systemic inflammation. You don't need to have those being elevated for psoriatic arthritis, but if they are, then it portends a somewhat more severe prognosis. So those who present with these markers elevated may be more likely to progress more rapidly. We also like to look at blood counts because chronic inflammation can cause anemia, and also very important in terms of some of the medications that we use. More recently, we've been using a lot of ultrasound imaging because ultrasound can not only look at the joint in real time, find erosive changes or damage to the joint, but also can document inflammation in the entheses that we were talking about, and that can be very helpful in making the diagnosis. We also use MRI, particularly sometimes for the spine or to make the diagnosis of spondylitis, which can also affect the sacroiliac joints, the 2 joints at the back of the pelvis that expand during childbirth, but are often affected early on in spondylitis, and CAT scans can also be helpful in certain situations. Why do we treat psoriatic arthritis? Well, for all the things you would come up with if I just asked you. It's to relieve the pain and the fatigue that's often associated with the inflammation of psoriatic arthritis. It's to reduce the swelling. And probably more importantly, to really help to limit further joint damage. So when patients come in to see me with psoriatic arthritis, it's because they're hurting and they're fatigued and they're having difficulty getting through their day and their activities of daily living. And they're thinking, gee, I want to have improvement in the pain and I don't want to see these swollen joints. And I'm thinking on my side, gee, we want to make sure that there's no permanent damage. You think about it with psoriasis, it's problematic when it's out and very inflamed and unsightly and itchy and uncomfortable. But when it goes away, it really doesn't leave any permanent damage. On the other hand, when joints are inflamed, if they're inflamed for a while and really not even taking that much time, there can be permanent damage that really never goes away. So we do feel it's urgent to treat early and fairly aggressively to get that inflammation under control. And of course, once we do get the swelling and the pain under control, we tend to improve quality of life, and that's really our underlying goal here. How do we decide what medications to use and how aggressively to treat? Well, part based on the severity of the psoriatic arthritis and especially functional status. And just as Dr. Prussick said about palmar psoriasis, that raises the severity, you can imagine that if somebody has swelling of one of the joints of their feet and they just have to walk into an office, well, that's very uncomfortable. But if somebody is a dentist or a concert violinist and they have dactylitis, complete swelling of an entire finger, that's an emergency because that person's functional status and ability to earn a living is going to go down very rapidly. We think about the use of other medications and the interactions, and we always now think of overall health and other what we call comorbid conditions, meaning other diseases that are also affecting the patient that may affect their psoriatic arthritis and may affect our choice of specific medications. So what are some of our treatment options? Well, one of the first things we often will use is a non-steroidal anti-inflammatory drug. These help to decrease inflammation and pain. They have both analgesic and anti-inflammatory effects. They can help to improve range of motion. They can be effective for the enthesitis that we talked about. They're generally taken orally, and they can be either prescription strength or non-prescription over-the-counter. So Advil and Aleve are NSAIDs, and so is prescription strength naproxen and meloxicam, Mobic, Dapro, and lots of others that are out there. There are also topical anti-inflammatories, non-steroidal anti-inflammatories, such as diclofenac gel that can be applied directly over a joint and go through the skin and into the joint. Those tend to need to be used fairly consistently, though, to be effective. These are some of the pain relievers and NSAIDs that we talked about, ranging from aspirin, which was available 50 years ago, to some of the newer prescription medications like Celebrex. And all of these can be quite helpful in reducing pain, inflammation, and stiffness, but all of them also have potential side effects. And the main things that we think about with all of these medications are GI irritation, gastrointestinal irritation, going as far as ulceration and bleeding, potential liver damage, and now we also know that all of these drugs, not just Celebrex or Vioxx that was taken off the market for this reason, can increase the risk of cardiovascular events. So we do want to be very careful about using these drugs in people with hypertension or prior cardiac disease. The next step is disease-modifying anti-rheumatic drugs, DMARDs. This is what has classically been used, and pretty much all that was used prior to the advent of the biologic therapies that we now have that help to revolutionize the treatment of this disease. So these do help to reduce joint inflammation and limit the damage that occurs over time. And these are all prescription drugs and can be taken through various different routes. These are the traditional systemic medications that we have used. The most common one has been methotrexate, and that was pretty much the only one that was used 25 years ago or so that could affect both the joints and the skin. Leflunomide or Arava is another medication that can be very helpful for the joints, but not really for the skin. And sulfasalazine also is a much milder drug used more in Europe for psoriatic arthritis and rheumatoid arthritis as a DMARD and anti-inflammatory. Each one has different dosing frequencies and different side effects. With methotrexate, we are most concerned about the liver, but over the years we've learned to monitor that very carefully, and with very careful monitoring, we often can avoid long-term side effects, but we do have to monitor that very carefully. There are some short-term side effects like mouth ulcers and hair loss that are very concerning to patients, but often can be ameliorated by using certain vitamins like folic acid or vitamin A. These all need to be monitored closely by a physician. One thing I just want to mention is in people who are on methotrexate, they do need to be careful about certain other medications, particularly Bactrim, and this is something I see unfortunately frequently. The combination of Bactrim and methotrexate can be quite toxic. Bactrim is an antibiotic that is often used for urinary tract infections, so people on methotrexate have to be careful about not using that drug. Dr. Prussick already talked about Otezla, one of the newer medications that we have that is also considered a DMARD. This was produced by Celgene and does seem to be helpful both for psoriasis and psoriatic arthritis, although I would say for milder forms of the disease. It does take a little while for Otezla to become effective, but it does have the benefit of being an oral agent. Biggest side effects are diarrhea with the initiation of the disease and unexplained weight loss, which sometimes is a problem and sometimes not. We do monitor carefully for depression, as Dr. Prussick had mentioned. Corticosteroids were mentioned a couple of times already in a negative light, and we do try to stay away from oral or systemic corticosteroids in patients with psoriatic arthritis for just the reasons Dr. Prussick mentioned. When corticosteroids are stopped when they've been used systemically, we can see a significant flare of psoriasis. We generally only use them in really severe cases where we need to get inflammation under control rapidly. We do, however, not infrequently use corticosteroids as a local joint injection. So if there is one joint that remains flared or inflamed, despite pretty good response to another medication, then we will often inject that joint to give more prompt relief in that one area without having to necessarily change medications. Actar Gel is another medication that's been out now for a number of years, originally used long ago to treat gout, but more recently with multiple indications. It's really used fairly infrequently. It is given injectably in one or a few doses and can get significant flares under control in some patients. Works through a couple of mechanisms. It causes release of endogenous or steroids that are produced by the body, and it works by inhibiting something called melanocortins, which can promote inflammation as well. And then we get to the biologics, and we had some discussion of this already with Dr. Prussick about the biologics that are available for psoriasis. Once again, these all inhibit something called cytokines. Cytokines are cell-to-cell mediators, and Dr. Prussick showed you early in the presentation some of the ones that are important in psoriasis and psoriatic arthritis, TNF-alpha, IL-17, IL-12-23. These cytokines are proteins that are really, I like to call them cell-to-cell communicators. I often explain to patients that a cytokine is like an invitation to the party. Inflammation is going on in one part of the body, and a signal has to be sent out to continue inflammation there or even start inflammation elsewhere. It's like an invitation to this inflammation party. These invitations are being sent out repetitively. These biologic response modifiers tend to intercept that cytokine or intercept that cell-to-cell mediator, and it's as if the invitation was sent, but it never reaches the mailbox that it was supposed to go to. And by never reaching that mailbox, inflammation can fairly rapidly come under control. So these drugs block overactive immune activity. They do reduce inflammation, and we know that they do inhibit the joint damage that can occur fairly rapidly and progressively in psoriatic arthritis. They have been very effective in clearing psoriasis as well as nail disease, which can be a little trickier, and are very effective, therefore, at treating really all of the domains of psoriatic arthritis. Some differences between the different medications. They're generally given injectably or by infusion, meaning intravenously through the vein. And you can see again on the bottom the different types, so TNF-alpha inhibitors, IL-17A inhibitors, the IL-12-23 inhibitors, and then also something called the T-cell co-stimulation inhibitor, which works through a slightly different mechanism. So these are our TNF inhibitors: Enbrel, Humira, Remicade, Simponi, and now a newer one called Simponi Aria, which is like Simponi but given intravenously, and Cimzia. All of these basically block TNF from going from one cell to another. They all inhibit the progression of joint deterioration and reduce the inflammation both in the joints and in the skin. The difference is, in part, how they're administered. So most of these are by self-injection, but Remicade is an intravenous infusion, and Simponi Aria is an intravenous infusion that's given generally in a doctor's office over a period of anywhere from 1 to a few hours. Again, different dosing schedules that you can see over here that differentiate these various different drugs. So in some people who would prefer not to have to inject themselves, they may want to go more with one of the infusible medications. For those who don't want to have to be coming into the office every other month, then the injectable medication may be better. Nothing comes for nothing, so there are many side effects to the TNF blockers. These include injection site reactions. Infections are by far the thing we worry about most because we are inhibiting the immune system, and that allows infections to get worse more rapidly and a little bit more susceptibility to infections. This is mostly bacterial infections, not as much viral infections. Some of the biologics can increase the risk of yeast infections like Candida. We watch for liver function abnormalities. There's been a lot of talk about the risk of lymphoma with these medications over time. And as Dr. Prussick said, these medications have been available now for going on to 20 years at this point. It looks like the risk of lymphoma is not as great as we thought. And in fact, just having an underlying autoimmune disease seems to be a more significant risk for developing lymphoma than using these medications and getting the disease under control. We watch very carefully for tuberculosis because the TNF-alpha cytokine is very important in keeping TB locked up in the body if you've been exposed to it and not becoming a full infection. If you give a TNF inhibitor, then that allows exposure to TB that previously was not a true infection to become a full-blown infection. We have a lot of ways of monitoring these medications, and we monitor for several different potential side effects. One thing that is very important for people to remember with all of the biologics is that we need to avoid live vaccinations. So that's a vaccination like the shingles vaccine and certain vaccinations that you would get if you were traveling abroad. Vaccinations like the flu vaccine or the pneumonia vaccine are not live vaccines and are not an issue with these medications. Again, things that you really want to be careful about if you're on a TNF-alpha inhibitor. Certainly, if you're taking any other biologic agent, you want to make sure that your doctor is aware of it. We don't usually use two biologic agents together. Again, we mentioned the live vaccines. Obviously, if there is pregnancy or if there's a history of cancer, particularly in the last 5 years, or a history of heart failure, if you're going to be having major surgery, or if there's any active infection, these are reasons for speaking to your doctor very promptly. Stelara was already mentioned in the treatment of psoriasis, is also effective in the treatment of psoriatic arthritis. This is a IL-12/23 inhibitor, so a different cytokine. It's very effective at reducing the skin inflammation and is also quite effective for the treatment of psoriatic arthritis. This is an injection, and it's given after initial loading dose at week 0 and week 4. It's given once every 12 weeks. So sometimes convenience plays a role in deciding which medication to use. So in people who would really rather just get a shot once every 3 months, this would be a very good choice for them. So that might be the case for, let's say, a college student or someone who needs to travel frequently, who can't get into the office for an infusion or doesn't want to be traveling with injections all the time. Again, we do monitor for TB and a number of potential side effects. The IL-17 inhibitors are some of the newer kids on the block. Again, quite effective for the psoriasis, often can completely erase the psoriasis in some patients. Cocentex is one of these, secukinumab, also quite effective for the treatment of the swelling and inflammation of psoriatic arthritis. This is a self-injection, but we have a lot more dosing flexibility in psoriatic arthritis than in just psoriasis. So the dose can vary between 150 milligrams or 300 milligrams. That again is self-injected every 4 weeks after the initial 5 weekly doses. This is one of the medications that we do want to watch for yeast infections like vaginal yeast infections or oral thrush. In addition, other infections need to be monitored as well. And we do screen for TB. One of the special things about the IL-17 inhibitors is that we are very careful to use them in patients who also have inflammatory bowel disease like Crohn's disease or ulcerative colitis, which is not uncommon in people with psoriasis or psoriatic arthritis to have a coexisting condition of inflammatory bowel disease. The IL-17 inhibitors may make those worse, so we are very careful with that. Orencia is a drug that's been around for a long time in the treatment of rheumatoid arthritis. This is a T-cell co-stimulation inhibitor, which is complicated to explain, but a couple of cells need to be involved when inflammation gets started. One has to stimulate the other for inflammation to occur, and this blocks that process. This was just recently approved for the treatment of psoriatic arthritis just over this summer. This has the option of being given either as a self-injection or as an intravenous infusion. Simponi Aria, I mentioned earlier, also a new kid on the block. Simponi itself, golimumab as a self-injection, has been around for a while in the treatment of psoriatic arthritis, but now we have the option of giving it as an intravenous infusion every 8 weeks. Taltz is another IL-17 inhibitor already approved for the treatment of psoriasis, as Dr. Prussick mentioned earlier, but has been submitted to the FDA for the treatment of psoriatic arthritis. The phase 3 trials that we were talking about earlier actually have now been presented and are complete and show an excellent response, an excellent effect on psoriatic arthritis. And it's expected that Taltz will be approved for psoriatic arthritis probably over the next several months. What other things can you do in addition to these medications that we're talking about, which have been incredibly helpful? In fact, as I mentioned earlier, these biologic medications have really revolutionized the treatment of psoriatic arthritis. But there are other things that you can do. So complementary and alternative medicine, such as acupuncture. Acupuncture has been very helpful for many patients to help to relieve pain. Probably doesn't really affect the disease process itself, but can really improve discomfort and improve functionality. One of the nice things after all that discussion about the side effects of various medicines, as far as we know, there are no side effects to acupuncture. Massage therapy, also very helpful because when joints are inflamed, muscles tend to get stiff, painful, and even atrophy. And massage can be quite helpful to improve comfort. I'm a big fan of physical therapy. I think that is very important to get people moving, to keep joints moving, to prevent contractures and damage to the joints, and to keep muscles strong. And really, we consider surgery only as a final option if there's been severe damage to a joint, erosions, such limitation that that functional status has really declined. I usually tell people that they will tell me when surgery is necessary. I won't tell them because it's really when they just can't get through their day anymore. We can do joint replacements, and those have come a long way over the last few decades. And also a fusion of a joint, if particularly in the hands, to prevent movement at that painful joint. So I'll just conclude saying again, early recognition is the key. You know, I just cringe when I see people who have been treated, you know, for the specific manifestations, let's say like Achilles tendonitis, without realizing that there's an overall disease process that needs to be managed, because early treatment can really make a difference. We know that long-term disability is affected by treating early, even within the first 6 months of diagnosis. We want to work with a full team of healthcare providers. In fact, we've been working very hard to bring dermatologists and rheumatologists together, to work together to manage this disease because we think just a little differently about it, and putting those differing opinions together actually is the best thing for the patient. It's very important for you as the patient to be informed and active in the treatment decisions. As I mentioned, many of the treatment decisions depend on patient factors ranging from preference of injectable to infusible to timing of medication administration. It is just essential to have effective treatment to prevent the permanent joint damage that can occur from psoriatic arthritis. And Dr. Prussick talked about lifestyle changes. I just again want to highlight the importance of weight loss in the treatment of psoriatic arthritis. That has clearly been shown to be helpful in lowering the burden of disease and making the medications more effective, and also smoking cessation. It is very clear now that smoking stimulates autoimmunity, maybe the actual trigger in many cases of rheumatoid arthritis, and clearly makes psoriatic arthritis worse as well. So I'm going to stop there. I'll turn it back over to our moderator, and thank you for your attention.
Thank you so much, Dr. Siegel, for sharing your insights with us. On the screen, you will see a slide highlighting our Chronic Pain Management Hub. If you've not visited that, we encourage you to look at that to be able to see the different types of pain, some pain management options, as well as treatment options that are available. And here's some additional resources for you as well. Unfortunately, we are at the end of our time, and so we will not have time today for our Q&A. But if you do have questions that weren't covered in tonight's presentation, you can contact our Patient Navigation Center by phone, email, live chat, or Skype. And once you leave today's webinar, you will receive a survey on the presentation, and we'd appreciate it if you complete that and give us your feedback. Once again, thank you to our sponsors, presenting sponsor Novartis, and our national sponsors Celgene, AbbVie, Lilly, and Mallinckrodt. And a special thanks to Dr. Presec, Dr. Siegel, and all of you for attending. Finally, I just want to mention that a recording of tonight's webcast will be available shortly on our website, and you can access our complete webcast archive by visiting psoriasis.org/webcast. Additionally, you can register for the next webinar in the Speed Joint Smart series featuring physical therapist Dr. Brian Blevins. Thank you, everyone, for joining us, and have a lovely evening.